I'm Scott Lim, professor of medicine and pediatrics at the University of Virginia. I'm a cardiologist and head up our advanced cardiac valve program. So patients with degenerative mitral valve disease have a disease such that with every heartbeat, their mitral valve leaks blood back toward their lungs. And as a result, those patients are symptomatic with shortness of breath and fatigue as their main issues. That impairs the quality of their life as well as the quantity of their life. There's some data that we have out there looking at the natural history of those patients, which does show that impairment to the quantity of their life, with on average a survival of about 8 years after a diagnosis of severe degenerative mitral valve disease in patients that do not have options to treat them. There's a family of devices called for transcatheter edge-to-edge repair. The concept behind these, what we call TEER devices, is they're a less invasive way to treat mitral valve disease. The TEER devices are introduced from a catheter going through the vein in the leg up to the heart over to where the mitral valve is, and then grab both anterior and posterior leaflets in the mitral valve, pulling them together to effect the repair. The latest generation of such devices is the Edwards PASCAL device, which again goes through the catheter and then is delivered to the mitral valve, where it has several relatively unique design features. It has a central spacer element such that when the operator grabs both leaflets and pulls them together, they don't have to be pulled quite as tightly together with as much stress and strain on the leaflets as with the predicate device, since it's just coming to that central spacer. Also, the entire creation of the PASCAL device is made out of a nickel titanium alloy, nitinol, and it's hollow. So there's an inherent flexibility in the device. And when you watch after it's been put in the patient, you can see throughout the cardiac cycle, the device flexes open and closed. And that, we think, has benefit to the patient in terms of its interaction with the mitral valve and physiology. Lastly, the entire device itself is relatively smooth and rounded with not a lot of sharp edges, such that it gives the operators a greater confidence that the operator can maneuver it through the heart without getting it stuck in places that would be detrimental. So overall, it has several design features that hopefully have translated into improvements for the physicians being able to use it to help their patients with mitral regurgitation. So the CLASP II D clinical trial was designed to evaluate in a head-to-head comparison 2 contemporary TEER devices. The predicate device is called the mitral clip, and that's the standard by which this newer PASCAL device was compared. It was studied in a non-inferiority design for both safety, which was defined as major adverse events at 30 days, and efficacy, which was defined as reduction of mitral regurgitation to 2+ or less, and that proportion of patients having that sustained at 6 months. There was an independent echo core lab adjudicating those results as well. The primary outcome of safety, which was a composite of major adverse events at 30 days, was met. It was very low in both arms of the trial and relatively no different, an absolute value of 1.3% between the 2 arms, which really speaks to not just the overall safety of the devices, but that the entire field, from the physician operators using the device to the imagers and so forth, have all improved such that we're getting some fantastic results that are very safe for our patients. Additionally, the primary efficacy endpoint, which is the proportion of patients achieving 2+ MR or less at 6 months, was also met with the absolute difference between the 2 arms of 0.3%, where both arms, be it PASCAL or MitraClip, 98% approximately of patients achieved and maintained 2+ MR at 6 months. A secondary analyses or secondary endpoints were also looked at, including the proportion of patients at 1+ or less MR. So even lesser grades of residual MR, similar to the best surgical results. And that was achieved at very high percentage of patients, over 80% in the PASCAL arm. There was some diminution of the 1+ or less results in the MitraClip arm. That'll need to be followed out over a longer period of time, but that perhaps was the early signal of a difference between the two. There was also other secondary endpoints of quality of life measures and patient physical performance measures, and all those showed in both arms significant improvements for the patients in terms of their ability to exercise and their quality of life measures. I think this trial was important because now it brings a second device to the armamentarium of physicians treating degenerative mitral valve disease. And it also shows very clearly that the entire field has progressed since we first started with the early Everest II trials more than a decade ago, and that the safety and efficacy of these therapies for our patients really has come a long way.